Thank you so much for that lovely introduction. It is indeed a pleasure to be in internal medicine. Just to tell you a story, when I was doing my cardiology fellowship training, I asked a cardiologist, why do you take up cardiology? And he said that it's very difficult to become a good internist. It's very easy to become a specialist. And I totally agree with that. I know that you already are feeling like Ramazan, and I'm just holding you back between the lunch. So I'll make it as short as possible because it's very simple things. I just want to introduce the idea of this molecule that is available and how and when to use this drug per se. I also would like to thank the organizers for giving me this opportunity. So this will be the outline for my presentation today. What is Paxlovid? How does it work? When can we use it? When we can't use it? UAE guidelines for Paxlovid and what is the summary. So let's start off with this patient. This is a 65-year-old male with hypertension, diabetes, has fever, cough, and sore throat for the last 3 days. He comes to the emergency department and COVID testing is positive. So what treatment options are available for him? But he also does not want admission for COVID. So I hope none of you have forgotten COVID. I know Dr. Umar has spent a lot of time in COVID wards. So any guesses for what are the options of treatment for this patient? So this is the NHS, the UK guidelines in 2024 in January. The treatment options here are nirmatrelvir. Please forgive me if I keep mispronouncing the name. It is really tricky. But I'll use the word Paxlovid for the same. Sotrovimab, molnupiravir, and remdesivir. So this is the NHS guidelines for the options for treatment of COVID in 2024. And this is the CDC guidelines, which has removed sotrovimab and has kept the other three, that is Paxlovid, remdesivir, and molnupiravir. Now, the oral options for COVID infection are two, that is Paxlovid and molnupiravir. As we all know, we are all very accustomed with remdesivir. We have been using for almost 4 years now, whenever we get an opportunity. So the idea of this presentation will only be to discuss when and how we can use this molecule, that is Paxlovid. The importance here is that it can be given for patients above 12 age group as well. It has to be taken orally. Remdesivir is a good molecule and a good antiviral, but has to be given IV, and healthcare facilities are necessary for it. As my previous speaker was suggesting, emergency medicine gets overwhelmed with COVID infections, and if they keep everybody there for remdesivir, that is going to be a challenge per se. So this is a slide from UpToDate. I want to go through from top to bottom. Basically, if you get a patient of COVID in the outpatient setting, how would you approach this patient? What are the options? As I mentioned, we have remdesivir, we have Paxlovid, we have molnupiravir. So these are three options that we have as in terms of antivirals. If the patient is a patient who's at high risk of developing serious infections, that is age of 65, are immunocompromised, have multiple medical comorbidities, or is above 50 years and unvaccinated. Fortunately, the last line doesn't hold good for UAE because most of us are vaccinated. Now, the trick here is that if the symptoms are less than 5 days, only then can you think of Paxlovid. After 5 days, the efficacy is not that great. So if already 9 days have passed since the symptom onset, just give him supportive care and that's about it. If in 6 to 8, you could still consider remdesivir or convalescent plasma. Again, the availability of convalescent plasma is very difficult. The next step, if you want to use Paxlovid, is to see if the liver and kidney are functioning well. So if the liver is functioning well, then you can think of giving Paxlovid, provided the kidneys also are functioning well. So that is the cue. So the patient needs to be somebody who can progress to severe disease. The patient's liver should be reasonably okay, and the patient's kidney should also be reasonably okay. Only then can you really consider. If these criteria are not met, you could still go with remdesivir, the good old drug. And remdesivir is a great drug that we have been using for a long time, and great clinical experience has come through it. A little bit of microbiology as to how this Paxlovid really works. Now, this is the initial how the story goes normally. If you see the arrow here, the SARS-CoV has a viral entry. It goes uncoating. It translates using the ribosome. It then has proteolysis, and this is the M-Pro proteolysis enzyme, which is important for proteolysis and therefore subsequently replicase transcriptase complex and packaging and then out for the next attack. Now, Paxlovid attacks this protease. Now, this activity is important for the virus to continue multiplying, and this Paxlovid helps to prevent or inhibit this enzyme and hence gives the clinical outcomes. Now, there's a lot of talk about is it going to be effective on alpha, beta, gamma, delta. I've also actually forgotten the number of variants that are available there. But this in vitro studies, multiple in vitro studies have shown that it is effective on most of the variants that are present. Now, the question might be, will this be true in the future? That will be a future question, but most likely because of its mechanism of resistance, it is a good likelihood that it will work on most of the variants. And I'll also not go through the details of these in vitro trials because most of them have suggested the efficacy of the molecule. I wanted to pay a little attention on this trial, and this is the only study that I'm going to show you because of shortage of time. Now, this is the EPIC-HR trial, which is a international phase 2-3 double-blind randomized controlled trial where they gave people less than 5 days symptoms Paxlovid, and they gave the same kind of placebo for the same. And at the end, they decided to see what is the chance of hospitalization and death from any cause. So if you see, the hospitalization relative risk reduction is almost 88.9%. So if you compare these two groups, if you give Paxlovid, there's a good likelihood that the patient will not progress to getting hospitalization. And that is the whole idea, right? We don't want patients to get into the hospital and then have complications from there onwards. So this particular trial was very important to show the role and efficacy of Paxlovid in COVID management. Now, if you see, the name has two things in it, nirmatrelvir and ritonavir. Now, why do we use ritonavir? For people who are used to treating for HIV, they know that ritonavir is used as a booster for HIV medications as well. So, co-administration of ritonavir enhances the bioavailability of nirmatrelvir by slowing its metabolism. The same concept which they use for HIV medication itself. So therefore, the package is with nirmatrelvir and with ritonavir together. So when can we use Paxlovid? What are the specific indications? Now, before we go into that, let's talk about this particular patient. A 30-year-old female with SLE who is on steroids comes with fever, breathing difficulty, and her SpO2 is 88%. Now, can we use Paxlovid in this patient? And should we use steroids in this patient? How much? How long? So this patient is definitely lesser than 94% of SpO2. That means she is hypoxic. So can we use the Paxlovid in this question? The answer is most likely no. Paxlovid is to be used for only those who do not require supplemental oxygen and who are at increased risk for progression to severe disease and within 5 days. So a person like me who is 36 years old, who is not having any comorbidities, who doesn't have any risk for progression, should I be taking this medicine? Most probably not, because it is not, I am at very low risk of getting hospitalized anyways. So giving this medication might not really be beneficial in the long run as well. So for that particular patient with SLE, once oxygenation requirement starts, the role of nirmatrelvir goes downwards. Now in that particular patient, can we use remdesivir? The answer is most likely yes, we could still use it. Just to remind you that there are phases in COVID infection. There is initial the viremia phase where the virus is a problem. After a few days where the pneumonia sets in, it's actually the inflammation that is a problem, where dexamethasone makes a big impact and not the antivirals per se. So how do we prescribe it? It's a little more complex because the dosage is 300 mg of nirmatrelvir. So the packaging is 150 mg. There are two 150 mg tablets which you need to take with 1 tablet of ritonavir. So this has to be taken. So basically you'll have 3 tablets in the morning and 3 tablets in the night, 12 hours apart. What if you really miss a dose? If within 8 hours, if you're remembering it, you could probably take it, but otherwise just continue from where you have left the situation. The best idea is to always complete the therapy, which will give you the best chance possible. Again, to remind you, if there are any nephro guys over here, nephrologists will not like to hear this, but if the patient is on dialysis or eGFR is less than 30, probably not the best idea to treat this patient. Again, you still have remdesivir, which you can give in this particular group of patients as well. But if the eGFR is anyway above 30, you could dose modify it and give the medication accordingly. What about liver? The hepatologist, again, if the patient has Child-Pugh A and B, you could still use it with monitoring. But for Child-Pugh C, it is not recommended because of side effects. What about patients who are HIV positive? Alhamdulillah, we don't have much of a population of HIV here in the UAE. But what about them? You could still use the molecule without any dose adjustments, even if they are on HIV or HCV medications per se. Again, the question, because it's Ramzan and most of the patients will ask it, do we take it before food or after food or with milk, without milk, with juice, not juice? So this can be taken with and without food as well. The tablets need to be swallowed whole and should not be chewed, broken, or crushed. So if a patient, elderly patient, is on peg tube feeding, that is going to be a challenge for using this antiviral drug. What about contraindications? Hypersensitivity, as always. Another important feature is, because we are using ritonavir to prevent the metabolism of nirmatrelvir, the other medications which the elderly patients are on will also be affected. So it's very important to use UpToDate or use your lexicon to make sure that the drug interactions are checked very well. So there's a big list of drugs that is possibly going to interact with the molecule, and therefore it is important that you always check before prescribing, especially antiarrhythmic drugs and anti-epileptic drugs, because that can have a important effect. Mind you, the Paxlovid is going to be given only for 5 days, so there might not be a long-term effect. But if there are any medications like the antiarrhythmic or anti-epileptic drugs which need particular level to be maintained, and in acute settings, you need to make sure that you take care of these contraindications or drug interactions. A lot of details have been spoken about the rebound phenomenon. So what is rebound? I'll spend a minute over here. Now, this is the recurrence of symptoms and or increase in SARS-CoV-2 viral levels after initial decline. So the patient gets better and then gets worse. Now, when you mean by worse, it is the emergence of or presence of symptoms which are mild. But the other thing is, sometimes you also see that the viral load goes upward. So the patient is positive, becomes negative, and then might become positive. Now, the incidence, again, depends on the studies that have done it, because it's difficult, right? If the patient is clinically stable, they would not probably come back, and you'd only get those patients who are actually coming back with symptoms. So the incidence, the precise incidence is uncertain, but roughly it's 1 to 2%. Some studies have given it to 5 to 15%. The important point here is, it's unlike other post-influenza bacterial infections where you have patients running nose, they become better, and then suddenly become worse and come to the ICU. So even when the recurrence is there or the rebound is there, the symptoms are still mild. Now, one challenge I see that is going to be a problem in this increase in viral load is if the patients are in a hospital setting admitted for some other reason, and infection control becomes a little problematic, because our idea is to discharge them after 5 days and send them home. But if they go home to other susceptible people, this viral upload or rebound might be an issue. But that's something that we need to keep in mind. Now, this occurs within the first days of stopping. It's also known with other antivirals, but the percentages keep on changing depending on the studies. And this is seen in both vaccinated as well as unvaccinated patients. Now, how do we manage this? If you repeat the antigen test and if it's positive, probably a good idea to actually isolate them. Alhamdulillah, in the UAE, we are moved on to the 5-day isolation policy. But they do not recommend to retreat the patient. Now, again, if the patient is immunocompromised, saying a bone marrow transplant patient is there, he's not too sick enough to be in the ward for remdesivir, but he's reasonably okay with mild symptoms. So in this particular group of patients, there have been physicians who have been using as an off-label to basically retreat the patient with the second course of action. So that is something that they have done as well. So these are our UAE guidelines. This was, I think, the last update was in May or August last year. So there are still changes that can expect in the coming days. Alhamdulillah, we don't have the number of patients that we had previously, which is a good thing to see. Again, above 12 age group, you could still give it. The limitations are if the patient is hospitalized. Now, again, a group of patients could be that the patient comes with, say, myocardial infarction, which happens in most of our hospitals. They come with myocardial infarction, they have got no pneumonia features, nothing. And when they test COVID, they turn positive. Now, in those group of patients, can we use it? The answer is most likely yes, because they're not having pneumonia and not having any hypoxia. Whether that is going to really change anything, because the whole idea of giving the molecule is to prevent hospitalization. They're already in the hospital. Will it really make a difference? That's slightly debatable, right? Again, the other issue is, can we use it as post-exposure prophylaxis? So if you remember, people who have been here in 2020, 2021, with favipiravir, a lot of people were just popping hydroxychloroquine, ivermectin, favipiravir. So can you use this? The answer is most likely no. Can you use this beyond 5 days? The answer is most likely no, because whatever effect is going to happen is going to happen in the first 5 days. And after that, it's probably going to be the inflammatory phase, in which case, mostly none of this is going to really work anyways. So again, what is mild, moderate, and severe? This is from our UAE guidelines. So if anybody has mild symptoms, is only with slight nausea, vomiting, headache, diarrhea, loss of taste and smell, but who do not have shortness of breath, and the oxidation requirement is more than 94%, or if FI or SpO2 is more than 94%. When you say moderate illness, what it means is there is dyspnea, the patient is breathless, and the respiratory rate is SpO2 is more than less than 94% basically. And severe is somebody who has PaO to less than 300 and respiratory rate more than 30. So the question is, if the patient is not breathless, but the chest X-ray shows a patch, again, most likely this might not be the best time to intervene in this particular patient. The same thing, repetition. How do we use it? The tablets are again 2 tablets of nirmatrelvir and 1 tablet of ritonavir. Again, most likely, again, I don't know this, but most likely why they did this, they could have just given 1 tablet of 300 mg and 1 tablet of ritonavir. But because kidney patients are there, in which case we have to half the dose of nirmatrelvir, this is a good idea to have 2 tablets. So you could take 1 if at all it's needed. It's not recommended again for EGFR less than 30 or Child-Pugh C. And this is the summary. So it's indicated for adults who do not require supplemental oxygen and who are at increased risk of progression to severe COVID-19. The recommended dose is 2 tablets of nirmatrelvir and 1 tablet of ritonavir for twice daily for 5 days. No dose adjustments are required for mild kidney or liver patients. Check the drug interactions specifically if the patients are pre-existing conditions. Because this molecule is for those patients who have comorbidities and elderly age who are already on other medications, it's very prudent to actually check your drug interaction checker and make sure that there are no drug interactions. Rebound phenomenon is possible, so you have to be aware of it and make sure that you inform this patient that if there is any symptoms, probably to come back at that stage. And that's about it. Thank you so much for your time.